So good evening to everybody. I'd like to thank you, Professor Smith, to giving the opportunity to come to Vienna and to see the snow, because for somebody like me living in Saudi Arabia, is exactly the opposite feeling that you have. When I see the snow, it's as you see a sunny day, so makes me a very special day. So I think that most of you, I think all of you, are wondering why to present something orbital stuff in a retinal meeting. And in Italy, when something like doesn't make sense in a context, we used to say it's like cauliflower or cabbage for breakfast. Then this morning, I had breakfast in the hotel, and I saw that you actually have cabbage or cauliflowers for breakfast. So this is the answer. So let's speak about minimally-invasive orbital surgery. Many of you, I think, think about oculoplastic as cosmetic procedures. And when we speak about minimally-invasive surgery, the first idea that we have is just to reduce, to improve the cosmetic outcome. Giving many talks on that. Minimally invasive surgery the main matter is not to reduce or to improve the cosmetic outcome. Is one of the points, but the key point is also that we have to make the proper management of the disease. We have to think about which one is the best for the treatment. Is it incisional biopsy, excisional biopsy, or we have to do the bulking? And this, we have to minimize damage to adhesion structures when is not needed. And another point is also to reduce the post-op care, which means reducing the hospitalization, which means that compliance outpatient is much better. So let's have a look to cosmetic. This I show you, this is the panoramic coronal approach. I have been trained with Professor Bononta, who was the one that introduced this approach. At that time, he think that the more you have the exposure of the orbit, the better is the chance to reduce the complication postoperatively. That is something that we shifting, and so we can have very nice decompression with this approach. And also you see this, we have good results, but this patient is 1 month post-op. As you can see, he still has some chemosis, he still has edema. So over the time, I shifting in reducing, not just me, all the community in oculoplastic, we shifting to reduce the postoperative outcome, complication, and management. And we try to think about with small to reach the orbit using small incision. And one of these is the swinging eyelid incision. This incision, as you can see, is very small, no skin incision, and is transconjunctival. And with this incision, you can reach almost all the parts of the orbit. I do, for example, I introduce what I call deep orbital fat decompression, which means that I remove for minimal proptosis, mild proptosis, only the inferolateral pocket, achieving very good result in terms of reducing proptosis. As you can see, this very small incision, I took like 5 millimeters of fat, and this is 1 day post-op. Yes, okay, there is some edema and chemosis, but it's 24 hours. And even, look, 24 hours post-op. So I think it's big achievement going for in terms of cosmesis. But let us look to management. What does it mean to introduce minimal invasive surgery for management? Is that, as you see, this is dermoid cyst. Again, one coronal panoramic approach. Okay, removal of the bone. But nowadays, what I do? Just a small incision and removal of the orbit. The same result with much less hospitalization and post-op morbidity. And because we realize that we have many small incisions that we can do to approach the orbit. And for example, lacrimal gland tumors, which is one of my favorite topics. In the past, we used to have a wide exposure removal of the bone of the lateral part of the orbit. And this because we think, especially when we deal with adenocystic carcinoma, that we have to remove the bone in order to prevent the spreading of the disease because of the perineural invasion. Now, we know over the time, and you can see it's a quite aggressive surgery. Over the time, as I report in this chapter, and in many studies that we have done, we realized that in terms of outcome and prognosis, there is no difference if you do a wide excisional removal of the tumor, or if you do a minimal just biopsy or excisional biopsy. And this because we know now that it's important to leave the bone unless it's completely invaded by the tumor. But when you have this just modeling, it's better to leave the bone because it works like a barrier to the spreading of the tumor. And so what I do now is small incision, just the removal of the lacrimal gland with the tumor. And this is teaching cases also that I used to present. It's very important also to prevent and to try to avoid as much as we can the aggressive surgery. This lady, this charming lady, came to my office just because she was complaining of ptosis. So I realized that she had like mild proptosis. I asked her, but have you noticed that? No, she said, no, I just noticed the ptosis. So I asked her for some picture. This was 30 years before, and you can see she already had ptosis and exophthalmos and proptosis in her left eye. So I did imaging, and as you can see, there is a well-defined lesion that looks and resembles the features of a pleomorphic adenoma. So pleomorphic adenoma is a benign lesion, but you have to remove the whole lesion, the entire lesion, because in order to prevent recurrences. So I did, as you see, it's a very well-defined lesion. So I did the removal of the whole lesion, and it turns out it was a lymphoma. For you, probably it's not important, but for us it's important. We removed the lacrimal gland, but this lady, she needed only a small biopsy. So we must have, it's not a matter of art or cosmetic. Minimal invasive surgery is also a matter of management, which is very important. We also published this paper. So what does it mean, reduce post-op morbidity? Look at this gentleman. He had a huge cavernous hemangioma. So what we used to do in the past is to remove the bone here, the lateral bone, in order to reach the lesion. And we think we used to say we have to expose the optic nerve that you can see here. It's dislocated laterally, and we have to dissect for the optic nerve. So, but nowadays, we changed completely. We think, why don't we try to find a different route, minimal invasive, like this, small incision. You see just less than 1 centimeter. I go here deep. It's very important. You have to have in your mind a 3D working way. And so I just digging in the orbit. I very careful move gently the retractors, and finally we have the cavernous hemangioma that we can just pull it out, as you see here, using just a hook, and it's out completely. And the morbidity, you look, small incision, and the patient the day after can go home. So even this case also, you see, this patient was 2400 with a compression of the optic nerve, and we did also small, it's not very visible, but anyway, small incision with exposure, very tiny space, but it's enough to remove. And see, this is 1 week later, just small scar here, because especially in the Middle East, the scarring is not that great, but she's very happy, 20/40 vision, no APD. Full motility. And another case, very deep, I want to show you, and also with a very tiny, small, but you have to know where to go. So one of my landmarks when I do orbital surgery is the optic nerve. I also, in my mentors, they used to say, for all the deep orbit you have to use lateral orbitotomy. No, I changed now my mind. If the lesion is lateral, as I showed already, I do lateral orbitotomy. But if it's medial, I go for medial route, and as you can see in this guy, is huge cavernous hemangioma, compressing the optic nerve, and there is high risk of stroke of the orbital apex because it's attached in the deep. But I did just small transconjunctival approach, and I pulled it out. Look, it's just this small incision, no bleeding, and this is the huge lesion, and 2020 post-op, this is 24 hours after the surgery. Again, another case that you can do also with the lid crease. So you can hide the incision in the lid crease. The patient doesn't have any scar afterwards, and you can reach the lesion. This is a schwannoma that I removed here, you can see, and is easily removed, no bleeding. Now I started also to do endoscopic, which of course is even another advances, another improvement. And of course, this is, you can reach the deep orbit, but you have to know very well where you are, because you can get lost easily with endoscopy. This case is also interesting to show once again why it's important minimal invasive surgery in orbital procedures. Look, this is 3-day-old girl with this proptosis in 2 weeks. So you can imagine the parents. It became double. So of course they called me, and you know which one is the problem? So again, talking about minimal invasive surgery, you know which one is the main problem? As I just said before during the lunch, I know that of course your work is very serious because you can make the patient blind. We can make also as an orbital surgeon the patient blind, but we can also make the patient die. The patient can die for surgery. The main problem in this little girl is that, how do you know how much blood she has? She has this blood, just 200 cc. So if during surgery you are not very gently manipulate all the structure, you are bleeding and you have lost. No way to save the life of and the parents, of course, they won't. Look how huge is the lesion. If you want, I have also the video. I don't know if you are interested, but just to show that I did very minimal approach. I have the movie if you want. So we can see in 2 minutes, but depends. I don't want to get you bored. And you can see that the results are quite nice. We save the eye, I don't know, the vision. And there was, of course, the family was quite happy with the result. So another example why it's important to plan a good surgery without, for example, make the osteoplasty. This lady developed this dermatitis because she was living very close to a amplifier radio station, so which means that she was living in a very strong electromagnetic field. And she developed this dermatitis. You know why? Because she had this surgery, quite aggressive for benign lesions, so not necessarily, and the suture, the metallic suture, anyway, with the electromagnetic field, make this dermatitis. So it's very important to have to do the minimal invasive surgery, to have the proper equipments. So of course I use also these kind of loop, which are very important. But now I started to enjoy also the 3D, not only the retinal surgeon, they are enjoying the 3D, even the orbital surgeon, they are enjoying the 3D. And I was one of the, according to the 7 different companies, I was one of the ones in doing the orbital surgery in 3D. And I think it's also helpful, probably in the future, can be one of the advances for the future to make minimal invasive surgery. So, just to summarize, minimal invasive surgery is absolutely important to improve surgical access, to minimize the morbidity post-op, and eventually, so the last and the least, not not only. The last important is to improve cosmesis, in my mind. And it's absolutely not a technical exercise. Thank you.
Thank Diego Strianese for this exciting